Neurological disorders, part 2. Degenerative disorders that we will be discussing are ALS, multiple sclerosis, Parkinson's disease, dementia, and Alzheimer's disease. Amyotrophic lateral sclerosis, aka ALS, Lou Gehrig's disease, is a progressive neurodegenerative disease that mainly involves the neurons responsible for controlling voluntary muscle movements such as chewing, walking, breathing, and talking. There is no cure for this disease. Amyotrophic means no muscle nourishment. Muscle tissue is wasting away without receiving impulses from the neurons. The etiology is not known. 10% of the cases are genetic. It occurs slightly more in men than in women. ALS was first found in 1869 by a French neurologist, but it wasn't well known until 1939 when Lou Gehrig, a great baseball player, developed ALS. Once again, it's classified as a motor neuron disease characterized by gradual degeneration and death of motor neurons that extend from the brain to the spinal cord into muscles throughout the body. These motor neurons initiate and provide vital communication links between the brain and the voluntary muscles. Messages from the upper motor neurons in the brain are transmitted to lower motor neurons in the spinal cord and to motor nuclei of brain, and from the spinal cord and motor nuclei of brain to a particular muscle or muscles. Signs and symptoms of ALS include muscle twitching in the arm, leg, shoulder, or tongue, muscle cramps, spasticity, muscle weakness affecting an arm, a leg, neck, or diaphragm, slurred and nasal speech, difficulty chewing or swallowing. One of the saddest features of this disease is that the person is usually mentally alert and cognitively intact. A famous actor who had the disease and died from it was Christopher Reeve. He died from ALS in 2004. When it comes to diagnosing ALS, there are no standard lab tests for upper motor neuron diseases such as this. But certain signs may be interpreted as signs of ALS. Examples of these signs are a positive Babinski's reflex, which signals damaged nerve paths, diminished fine motor coordination, muscle cramps, which can be painful and twitching, spasticity, which is a specific type of stiffness that causes jerky, hard to control movements, loss of the ability to speak, and it can also be confirmed with electromyography and nerve conduction tests. The treatment for ALS is generally focused on treatment designed to help control symptoms. Riluzole has been approved for treatment, and it may help to slow the progress of the disease. Without insurance or third-party coverage, the out-of-pocket cost for this medication can be about $1,200 a month. With coverage, co-pays tend to range from $20 to $200 a month. Medicare and the VA cover it. Assistance is also available to help support the cost of this medication. Other medications that may be prescribed to help in the treatment of ALS are drugs such as baclofen or diazepam to help with the control of the muscle spasticity. Gabapentin may be prescribed to help control pain. Trihexyphenidyl or amitriptyline may help patients swallow saliva. Most of these patients end up on a ventilator because of a non-functioning diaphragm that occurs. Most people with ALS die as a cause from respiratory failure, and this is usually within 3 to 5 years from when their symptoms first appear. Patients with ALS may need further treatment as their disease progresses. Sometimes they may need feeding through a PEG tube because choking is a common occurrence that happens. Some may need referrals to therapy such as physical therapy, speech therapy, occupational therapy, and a referral to an ENT doctor may also be recommended. There are 3 types of multiple sclerosis. They are as follows. Number 1, relapsing remitting type. Number 2, secondary progressive type. And number 3, primary progressive type. Relapsing remitting MS is the most common type of multiple sclerosis. About 85% of people with MS are initially diagnosed with this type. It is characterized by temporary relapses, flare-ups, or exacerbations when new symptoms appear. Secondary progressive MS, the symptoms worsen more steadily over time with or without the occurrence of relapses and remissions. Most people diagnosed with this type will transition to, most people diagnosed with relapse remitting MS will transition to this type. Primary progressive MS. This type of MS is not very common. It occurs in about 10% of people with MS. It is characterized by slowly worsening symptoms from the beginning, with no relapses or remissions. Being familiar with the nervous system can help with understanding the disease process of multiple sclerosis. The neuron is the basic cell of the nervous system. Neurons can be either myelinated, which is when they're surrounded by a myelin sheath, or unmyelinated. The myelin sheath is made up of Schwann cells and gaps between sections in the sheath, which are the nodes of Ranvier. The main functions of the myelin sheath are acting as an electrical insulator for the neuron. The sheath prevents the movement of ions into or out of the neuron, and it also speeds up conduction and transmission of an electrical impulse from one neuron to another. In multiple sclerosis, there's damage to the myelin coating around the nerve fibers, which interferes with the transmission of nerve signals between the brain, spinal cord, and the rest of the body. The disrupted nerve signals cause the symptoms of MS. Signs and symptoms of MS are visual symptoms, possible trigeminal neuralgia, limb weakness, easily fatigue, dysarthria, incoordination of limbs and trunk, bladder symptoms, paresthesia, and attention deficits. Differential diagnoses can include spinal cord neoplasms, acute disseminated encephalomyelitis, sarcoidosis, transverse myelitis, infarction of the spinal cord, vasculitis, and small vessel ischemic disease. The diagnosis of MS requires the demonstration of multiple CNS lesions that develop over time and in different locations. There are different tests that can be performed to help confirm the diagnosis. A lumbar puncture with the evaluation of the cerebrospinal fluid may be performed. An EMG test that is positive for 3 of 4 extremities may help to support the diagnosis. A CT or MRI of the brain, and also an EEG for evaluation of lower motor neuron pathways as well as upper pathways. Treatment and management for MS. A referral to a neurologist. Care may be co-managed between a specialist, and the primary care provider. Good prognostic indicators for MS include number one, minimal disability after 5 years of onset, complete and rapid remission of initial symptoms, onset at age 35 or younger, only one symptom during first year, brief duration of most recent exacerbation, and long first remission. Poor prognostic indicators of MS are late onset. These include chronic progressive course, motor symptoms, polysymptomatic onset, and vertigo. Currently, there's not a cure for MS, so the focus is mainly on the principles of management, which include delaying the progression of the disease, managing chronic symptoms, and treating acute exacerbations. Also, patients with this disease are in need of a lot of support. They can be referred to local support groups. There are also online sources such as National MS Society. Medications prescribed to patients with MS are corticosteroids for acute exacerbations, interferon and natalizumab for relapsing remitting types, antispasmodics or implantable drug infusion pumps, medications to manage spasticity and tremors, and also medications to help with pain management for acute and chronic pain. Patients with MS will need to be educated on all aspects of the disease progression. They also need to be counseled on medications, adverse effects, complications that may arise with their disease, pain management, and also diet and exercise. Parkinson's disease is another degenerative disorder. The etiology is unknown. However, there are several theories as to how the disease occurs. These include atherosclerotic vascular disease, environment toxins, viral infections, and genetic predisposition. The incidence and prevalence, 3 out of 2 is the ratio of men to women. It is usually diagnosed at or around the age 50. Parkinson's disease belongs to a group of conditions called motor system disorders, which are disorders that are the result of the loss of dopamine-producing brain cells. It is a neurodegenerative disorder that affects predominantly dopamine-producing neurons in a specific area of the brain known as the substantia nigra. Being familiar with the neurotransmitter dopamine is very important in understanding Parkinson's disease. A quick review of the AMP. Nerve cells in the substantia nigra produce the neurotransmitter dopamine and are responsible for relaying messages that plan and control body movement. Impulses travel from neuron to neuron, from the axon of one cell to the dendrites of another. By crossing over the synapse between two nerve cells, neurotransmitters such as dopamine allow the electrical impulse to cross the synapse. For reasons not yet understood, the dopamine-producing nerve cells of the substantia nigra begin to die off in some individuals. When 80% of dopamine is lost, Parkinson's disease symptoms such as tremor, slowness of movement, stiffness, and balance problems start to occur. The 6 cardinal features of Parkinson's disease include number 1, tremor at rest, number 2, rigidity, number 3, bradykinesia or hypokinesia, number 4, flexed posture, number 5, loss of postural reflexes, And number 6, freezing phenomenon. What are tremors? Tremors are an involuntary rhythmic muscle contraction leading to shaky movements in one or more parts of the body. It most often affects the hands but can also occur in the arms, head, vocal cords, torso, and legs. It may be intermittent or constant. It can occur sporadically or happen as a result of another disorder. Tremor is most common among middle-aged and older adults, although it can occur at any age. The disorder generally affects men and women equally. A tremor is not life-threatening, however, it can be embarrassing and even disabling, making it difficult or even impossible to perform work and daily life tasks. It is a very common presenting symptom of Parkinson's disease. There are different classifications of tremors. An essential tremor is an action tremor. It's in the wrists and hands when patients hold their arms in front of themselves, resisting gravity, but can also affect the head, lower extremities, and voice. It's generally bilaterally and it interferes with activities of daily living. Typically have no other neurological findings. Parkinsonism tremor begins as a tremor at rest with a low frequency pill rolling motion of the fingers, progressing to forearm pronation, supination, and elbow flexion extension. It is typically asymmetric and occurs at rest and becomes less prominent with voluntary movement. An enhanced physiologic tremor comes and goes with anxiety, medication use, and caffeine intake. Drug and metabolic induced tremors are tremors caused by epinephrine, albuterol, amphetamines, terbutaline, and psychoactive medications. Rigidity can be defined as stiff or inflexible muscles. It is most noticeable when moving a joint through a circular movement. Bradykinesia or akinesia occurs when actions like walking, getting out of bed, and even talking become harder and slower. It is caused by slow transmission of nerve impulses. It can give a face an expressionless, mask-like look. There are different postural disturbances that may present with patients with Parkinson's disease. For example, arms stop swinging naturally as the person walks. Steps become short and shuffling. They may also have trouble walking around corners or feel as if their feet are glued to the floor. In the picture, you can see a typical appearance of a patient with Parkinson's disease. Later stages of Parkinson's disease that may present in the clinical setting are impaired writing reflex, meaning reflex that corrects the orientation of the body when it is taken out of its normal upright position. Akinesia, rigidity, ataxia, festinating gait, stooped posture. Excessive salivation, dysphagia and constipation, low volume pitch, monotony and dysarthric speech, expressionless face and decreased blinking, increased cogwheel rigidity and tremor, positive Romberg's test, and inability to walk backward, and confusion, hallucinations, and dementia. Diagnosis can only be confirmed on an autopsy. CT or MRI scan is used to rule out treatable disorders. Electrolytes, thyroid function tests, lead levels help to rule out exposure to environmental toxins, and also because their face can show like a flat effect, they want to rule out depression. So different tests are used to rule that out. The Unified Parkinson's Disease Rating Scale is used to help monitor the progression of Parkinson's disease. There are 5 stages. Stage 1 is the mild disease, one limb, slight tremor or change in speech, facial expression, posture change or movement. Stage 2 involves 2 limbs, early postural changes, social withdrawal, and depression. Stage 3, there are significant gait disturbances and moderate generalized disability. Stage 4, akinesia, rigidity, and severe disability. Patient is still able to walk or stand unassisted. Stage 5, patient is unable to stand or walk, perform all ADLs. They are wheelchair bound or bedridden unless aided. Parkinson's disease is one of the most expensive neurological diseases when it comes to considering medications, treatment, hospitalization, loss of productivity, and disability. The goal of management is to control the symptoms. A controversy question is when to start neuroprotection therapy and also when to introduce levodopa. The importance of levodopa is that it helps to protect vulnerable neurons, which may slow or stop the disease progress. Some recommend early intervention to maximize clinical benefit, while others advocate delay to minimize risk of motor complications or accelerating disease progression. Drugs commonly prescribed for this disease are listed on page 114 in your dump fee book. And also use of the US PDRS scale is very important and helps with monitoring the patient's response to their therapy and management. The next disorder we are going to talk about is dementia. When referring to dementia, we are talking about memory changes, language changes, perception and recognition changes, purposeful movement changes, complex thought changes. There are different types of dementia. Alzheimer's disease is the most common. There's also frontotemporal disorders, also known as Pick's disease, Lewy body dementia, vascular dementia, and mixed dementia. Conditions that can mimic dementia but go away when condition is treated are as followed: some medications, depression, alcohol intake, head injuries, CVA, AIDS, and thyroid, liver, or kidney problems. Dementia makes the brain smaller. It also affects blood and oxygen levels. As it progresses, simple daily activities become more difficult. When it comes to Alzheimer's disease, there is a fine line between forgetfulness related to age and the onset of Alzheimer's. Word finding difficulty becomes more evident in trouble doing routine tasks, and it also progresses to experiencing difficulties with simple tasks. The causes of Alzheimer's are unknown. However, there are several factors that people have considered, such as neurochemical problems, deficiencies such as acetylcholine, somatostatin, substance P, and norepinephrine, environmental factors, and also genetics. Clinical presentations of Alzheimer's are as followed: insidious onset, forgetfulness, recent memory loss, difficulty learning, remembering new information, deterioration in personal hygiene and appearance, gradual difficulty in abstract thinking and activities requiring judgment, progressive communication difficulty, severe deterioration in language, memory, and motor function. Personality changes. They may become more restless and irritable. Once overwhelmed with anxiety, the patient may become acutely confused, agitated, compulsive, dysfunctional, or fearful. This progresses to disorientation, emotional liability, and intellectual and physical disability. Patients become susceptible to accidents and infections when they have these symptoms. There are several different tests that are done to assess the cognitive function of patients. The mini mental status exam is very common in the clinical setting. There's the Montreal Cognitive Assessment, which is a brief tool for mild cognitive impairment. Functional Activities Questionnaire, which can be good to use as a baseline. The clock drawing test. And also there are diagnostic tests that can be performed, such as lab tests to help rule out other conditions that may impair brain function, and imaging tests such as a CT and an MRI. There are several different medications that are used in the treatment of Alzheimer's. In your Don't Feed book on page 109, there are a list of drugs commonly prescribed. Examples of these drugs are Aricept, Exelon, and Namenda, which are very common drugs that you may hear in the clinical setting. Other medications that may be used in the treatment of Alzheimer's are antidepressants, anxiolytics, and antipsychotics. Medications used in the treatment of Alzheimer's include cholinesterase inhibitors and NMDA, which are very commonly prescribed. On page 109 in your Don't Feed book, there is a list of commonly prescribed medications. A few examples are Aricept, Exelon, and Namenda. Other medications that may be given for patients who present with Alzheimer's are antidepressants, anxiolytics, and antipsychotics. This chart represents drugs commonly prescribed for Alzheimer's disease, along with adverse reactions and prescribing considerations. In patients with Alzheimer's, referrals may need to be given. Home health may need to be considered as they slowly decline in being able to perform activities of daily living. Support groups, memory disorder centers, patients need to be made aware that they need to follow up as often as necessary to monitor drug use and their mental status. Respite care may be needed for the patient's family, and caregiver support. We are now going to be discussing cerebrovascular accident, also known as CVA. It is also referred to as stroke, brain attack, brain infarct. It is the sudden onset of neurological signs and symptoms, which are usually focal and acute. The leading cause of disability in adults. As the baby boomers age and experience CVAs, costs are predicted to greatly increase. This is the fifth leading cause of death in the United States, and it's highest in the Southeast. There is a need to continue improving in the control of risk factors to help prevent CVAs from occurring. Modifiable risk factors for CVAs include hypertension, cardiac disease, diabetes, hypercholesterolemia, smoking, illicit drug use, and lifestyle factors, which contribute to obesity, physical activity, diet, and stress. The two types of CVA are hemorrhagic and ischemic. Hemorrhagic is caused by an intracerebral hemorrhage, which can be caused from a ruptured aneurysm, AV malformation, or head injury. Ischemic CVAs are caused from an obstruction to blood flow, which can be caused by atherosclerosis, embolus, thrombus, hemorrhage, or vasospasm. Transient ischemic attacks, also known as TIA, and a lot of times are called mini strokes, are a warning sign of serious underlying atherosclerotic vascular diseases. It is defined as a temporary focal cerebral dysfunction where there could be ischemia involved or deficits and symptoms which last less than 24 hours and usually no more than 10 minutes. If the symptoms do last more than 4 hours, there could be death to neurons. Deficits lasting more than 24 hours indicate that there has been significant neuron death. There are several different signs and symptoms to a CVA. Common ones are weakness, numbness, paralysis on one side of the body, severe headache, cognitive impairment, where patients have memory impairment or speech problems and writing difficulties, visual changes, where a patient may have blurry vision or blind spots. This picture demonstrates the cross-section of the brain and gives a few examples of possible symptoms caused by damage from strokes in different areas. This diagram represents signs and symptoms of a TIA or CVA according to which side the brain injury is on. A mnemonic that is commonly used and heard in the hospital setting helps to do a rapid assessment on patients who present with stroke-like symptoms. And that is the word FAST. F stands for face. You want to check their face. Do they have any facial drooping? A are arms. Can they lift both their arms? S is speech. Are there any problems with their speech? Do you understand what they are trying to say? And do they seem to understand what you are trying to say? And T is for time. This is critical. Knowing the onset time is very important. Differentiating between a TIA or a stroke can be very important. A TIA is the only warning that a stroke is pending. It is estimated that there are approximately 30,000 new TIAs per year. People who have experienced TIAs are more likely to have a stroke later. Most patients who have a TIA have a short benign course, but up to 20% will have a stroke within the next 90 days. Half of those who will have a stroke will do so in the first 7 days after their TIA. The risk of a stroke following a TIA does vary. The ABCD2 risk stratification tool is very useful in helping to identify those at high risk of having a stroke. Scoring of ABCD2 helps to determine the risk of the stroke using the score, and the scores are divided into high, moderate, and low. The NIH stroke scale is used in facilities that care for stroke patients or those who present with stroke symptoms. It assesses the level of consciousness, alertness, ability to follow commands, eye movement, visual fields, and their motor and sensory functions. Diagnostic tests used on those who present with CVA symptoms are labs such as CBC with the platelet count, PTT, electrolytes, BUN, creatinine, glucose, calcium, magnesium, and ESR. EKGs are also performed in chest x-rays. A non-contrast CT of the head, MRI of the head, and sometimes Doppler ultrasounds of carotids. The diagnosis of CVA is given to patients based on findings of diagnostic tests and also if they've had neurological deficits longer than 24 hours. If a patient presents with TIA symptoms, there are several different treatments that can help to prevent a stroke from happening. If a patient has more than 70% of stenosis, a carotid endarterectomy may be performed. This should be performed within 48 hours in high-risk patients and 28 days to prevent strokes. Medications that help with atrial fibrillation and other antiarrhythmias may be prescribed. Anticoagulations help to increase the risk of clots. Aspirin, 75 to 300 milligrams daily. in the treatment of the arrhythmia. Secondary prevention for a patient with a TIA may include antiplatelet therapy or anticoagulation. Managing and monitoring patients' blood pressure is very important in helping to reduce the risk of a stroke, and also medications to help prevent high cholesterol levels or to keep their cholesterol levels down. There are several different lifestyle changes that patients may need to make in order to help to decrease the risk of having a stroke. These include smoking cessation, alcohol intake, exercise, and diet. Patients who present with stroke-like symptoms need to be referred to the hospital immediately. Other referrals that may become involved when a patient has a stroke or stroke-like symptoms include neurosurgeon or neurologist, depending on the type of CVA, physical therapy, occupational therapy, and speech therapy when indicated. And also, as mentioned earlier, local support groups will help with patients as they learn to live with their symptoms that they may have as a result of their stroke. And also psychological counseling will help with coping. We will now be discussing infectious disorders. Examples of these are meningitis, encephalitis, herpes zoster, trigeminal neuralgia, Bell's palsy, Guillain-Barré, and myasthenia gravis. Meningitis is the inflammation of the meninges in the subarachnoid space. It may result from infections, other disorders, or reactions to medications. The severity and acuity vary. It may be acute, subacute, chronic, or recurrent. Signs and symptoms of meningitis may include headache, fever, nuchal rigidity, phonophobia, nausea, vomiting, and petechia. When assessing a patient with signs and symptoms of meningitis, there are different techniques and assessments that you want to perform. With nuchal rigidity, the patient cannot flex their neck to place their chin on the chest. In this case, there's an involuntary muscle spasm which limits the passive neck flexion. The picture in the slide shows how the Koenig sign is performed. A patient lies supine, flex both hips and knees to 90 degrees as you hold the hip immobile and extend the knee. A positive test is if a patient is resistant to knee extension and there's pain in hamstrings. The Brzezinski sign is another technique used to assess patients with signs and symptoms of meningitis. The patient lies on their back and they bring their head forward towards their chest. Pain or resistance indicates meningeal irritation, arthritis, or neck injury. A positive result is when a person responds by flexing the hips and knees when the technique is performed. Using these techniques and signs are very important in the assessment of patients who present with the signs and symptoms of meningitis. However, they are not 100% accurate, so therefore the decision should not be based on positive signs of these tests. Meningitis can present with different signs and symptoms based on the type of meningitis. We have bacterial meningitis and viral meningitis. Bacterial meningitis usually presents as acute or gradual onset 1 to 3 weeks after an upper respiratory infection. Patients may have a fever, severe headache, drowsiness, nuchal rigidity, irritability, and seizures. With the viral meningitis, they may have a fever and a headache, and the nuchal rigidity is more pronounced. They may have nausea, vomiting, photophobia, and generalized aches. The diagnosis of meningitis is by cerebrospinal fluid analysis. Acute bacterial meningitis is more serious and rapidly progressive compared to the viral meningitis. Viral and non-infectious meningitis are usually self-limited. Treatment for meningitis includes antimicrobial drugs as indicated, plus adjunctive measures. Prevention is the vaccine. Encephalitis is an infection of brain parenchyma or brain tissue. Meninges are also usually inflamed. It is most commonly caused by a virus, such as the herpes virus or the West Nile virus. Patients usually present with an altered level of consciousness, and they may have other signs and symptoms such as an abrupt onset headache, fever, other signs of increasing intracranial pressure, nuchal rigidity, and hyper-responsive deep tendon reflexes. Increased intracranial pressure, also called ICP, occurs with encephalitis because the brain is inflamed and also swells, but it is confined within the space of the skull, so pressure within the cranium increases. Other causes: meningitis, which causes an inflammation of the meninges, which obstructs the flow of the cerebrospinal fluid around the brain and the spinal cord. As a result, the cerebrospinal fluid backs up and increases pressure. Hemorrhagic strokes, brain tumor, and head trauma are also causes of ICP. If the pressure becomes too high, brain tissue will displace through the foramen occipitalis. This is referred to as brain herniation. In this case, drains may be inserted to help decrease the pressure. This is an emergency situation, and patients with this need to be sent to the emergency room. The diagram on this slide shows sites of brain herniation. Tests that may be ordered to help with the diagnosis of encephalitis include a CBC, a chemistry, an MRI of the brain, a spinal tap for cerebrospinal fluid, and an EEG. Now we will discuss the treatment for encephalitis. Because complications from encephalitis can be very serious, the condition does require hospitalization of the patient. Treatment depends a lot on age and condition, as well as the form and cause of the disease. Bacterial encephalitis is treated with antibiotics. Encephalitis caused by herpes can be treated with an antiviral, such as acyclovir. Other treatments may be used to help with the symptoms, such as lowering fever, provide hydration, treat seizures, and reduce pressure in the skull. With proper care, many people do recover from encephalitis. Infants and elderly people are at the greatest risk of sustaining permanent brain damage. Herpes zoster, also known as shingles, is another infectious disease. Pain usually presents 2 to 3 days before eruption of a rash. Usually the pain gets worse at night or with temperature changes. Patients will have a unilateral vesicular rash along a dermatome. Lesions will continue to develop for approximately 3 to 5 days, and the disease course usually lasts 10 to 15 days. Management of herpes zoster includes managing healed vesicles, antiviral agents, medications to help with pain relief, such as systemic corticosteroids or soothing lotions for the lesions, and also you want to help to prevent secondary infections or complications such as postherpetic neuralgia. In these cases, sometimes a medication such as gabapentin may be prescribed. Prevention of herpes zoster. 1 in 3 people will develop zoster in their lifetime. The shingles vaccine is recommended by the Advisory Committee on Immunization Practices. This vaccine is to help reduce the risk of shingles and its associated pain in people aged 60 years of age or older. Also, the vaccine is given to people who have previously developed shingles. We will now discuss trigeminal neuralgia. This presents with chronic pain on one side of the face. It usually lasts for a few seconds and follows the trigeminal nerve distribution. Since it affects the trigeminal nerve, mild stimulation of the face, such as from brushing the teeth or putting on makeup, may trigger a jolt of excruciating pain. It is diagnosed based on clinical history. Management for this is remission and also Tegretol or gabapentin or TCA to help with the symptoms. Bell's palsy is an idiopathic cranial nerve 7 palsy causing lower motor neuron facial paralysis. It typically occurs on one side of the face. The cause of it is most likely to be viral, typically from HSV infection. Bell's palsy has a rapid onset. As mentioned earlier, it is believed to be caused by a virus. It subsides spontaneously in approximately 80 to 90% of patients. Patients may present with the following symptoms and signs: unilateral or bilateral facial weakness, pain around the jaw or behind the ear, their mouth may droop, and impaired ability to close their eye. Management of Bell's palsy includes preventing injury to the eye. Medication administration is controversial due to the self-limiting condition. A referral or a follow-up may need to be made. If there are corneal abrasions, a referral to an ophthalmologist would be beneficial, and a neurologist consult if they have neurologic signs which are evident or symptoms that are not resolved in 6 months. Corticosteroids may be prescribed to help reduce inflammation. Antiviral or antibacterial medications may also be prescribed. However, this is controversial since the disease is self-limiting. Over-the-counter pain medications may be recommended, such as ibuprofen or acetaminophen, and eye drops and an eye patch may be prescribed. Guillain-Barré syndrome is an autoimmune disease that may be preceded by a bacterial or viral infection. First symptoms of this disorder usually include varying degrees of weakness or tingling sensations in the legs. It's usually symmetrical. In many cases, the symmetrical weakness and abnormal sensations spread up to the arms and upper body, and it may increase in intensity until certain muscles cannot be used at all. And when it is severe, the person is almost totally paralyzed. In these cases, the disorder is life-threatening, potentially interfering with breathing, and at times with blood pressure or heart rate, it is considered a medical emergency. After the first clinical manifestations of the disease, the symptoms can progress over the course of hours, days, or weeks. Most people reach the stage of greatest weakness within the first 2 to 3 weeks after the symptoms appear. And by the 3rd week of the illness, 90% of all patients are at their weakest. Treatment for Guillain-Barré syndrome includes plasmapheresis, high-dose IV immunoglobulin therapy, and also to maintain the patient's body functioning during recovery, which may involve requiring the patient to be placed on a ventilator, passive range of motion exercises, or physical therapy when function begins to return. Myasthenia gravis is a relatively rare chronic autoimmune disorder in which an antibody targets the receptor for acetylcholine at the neuromuscular junction. It occurs in approximately 5 to 15 individuals per 100,000, and more women are affected than men. The name means grave muscle weakness and causes muscle fatigue and weakness associated with use. Hallmark finding: muscles weaken with use. The first noticeable symptom is weakness of the eye muscles. In others, difficulty in swallowing and slurred speech may be the first signs. The degree of muscle weakness varies greatly, ranging from a localized form limited to eye muscles to a severe or generalized form in which many muscles, sometimes including those that control breathing, are affected. Diagnosis of myasthenia gravis may include history, physical assessment, and labs. A CT or MRI of the head may be ordered to help check for thymoma, which is a tumor that sometimes occurs with myasthenia gravis. Treatment may include anticholinergic agents, which help to improve neuromuscular transmission and increase muscle strength. Also, immunosuppressive drugs such as prednisone or cyclosporin may be prescribed to help improve muscle strength by suppressing the production of abnormal antibodies. And also sometimes a thymectomy may be ordered if it is applicable to the patient.